Welcome. I don't know whether this is the 13th or the 14th time I'm doing this, but for some of you who are not familiar, this is how we're going to go about it. I'll present the case. I want a show of hands from the audience because I want your opinion. Then we'll have comments from the discussants. I'll tell you what I did. And then there's time for brief questions at the end of the session. So there'll be really 3 topics only here, okay? So let's practice beforehand. Typically I give you a cricket question. I was hoping today would be the gold match, but it's not, unfortunately. Which is the only country which has won the gold without conceding any goal in the entire tournament? A, B, some B's, okay, C, okay, D, E, panel, you want to guess? A, which year? Very good, very good. 1, yeah. Okay, it's very good. Remember 1928 and 1956. Okay, so that's how we're going to go about it. Okay, now the first case is on portal hypertensive gastroenteropathy and gave. Who's very confident they can treat PHG? No one? Okay. Very confident that they can treat gave. 1, 2, 3, 4. Okay, some. And who's very confident they can treat both? Okay, so then there's a lot of teaching to be done. What about you, panel? Very confident? Manas, C? No, okay. So let's start, okay? Let's start with a case. Male, intermittent melena, MELD 12, hemoglobin 6.8, low ferritin. So this is iron deficiency anemia. Colonoscopy is negative, and this is what the upper endoscopy shows. Okay, so show of hands from the audience. What is your diagnosis? Melena, iron deficiency anemia. Who says mild portal hypertensive gastropathy? Severe? Oh, very impressed. Gave? Okay. You agree? Okay. Now what's your initial treatment going to be? Non-selective beta blockers? Argon plasma coagulation? Okay. Tips? Something else? Okay. What do you think? Let's start. Narendra, do you want to start? And Arun, you're free to give the microphone to somebody else if you don't know the answer. Okay? You've done that before. Okay. So, what was your first choice? I didn't hear. Okay.
Beta blockers first, TIP second, liver transplantation third.
Okay. So if your initial therapy fails, whatever you started, some of you wanted beta blockers, some of you wanted argon plasma coagulation, few said TIPs, few said something else. Okay. What's your next choice going to be? Whatever you decided, what's your next choice going to be? Non-selective beta blockers? Let's say you started with argon plasma coagulation. If that failed, would you go to non-selective beta blockers? Argon plasma coagulation? TIPS? Combine non-selective beta blockers and APC? Okay, so we've got a wide variety of opinions here. So these are the questions that are related to the case. First, what is the diagnosis? Second, non-selective beta blockers or endoscopic treatment, because that seemed to be the 2 main things. What if bleeding persists despite beta blockers or endoscopic treatment? Is there a role of TIPS? And what about other drugs? Okay, so we'll try and cover all these in this case. Okay. So I'll go over differentiation, management, portal hypertensive gastropathy, vascular ectasia, endoscopic and pharmacological. Don't forget pharmacological treatment here. And then we'll have some take-home messages related to this case. Okay. How do you differentiate? Samagra, how do you differentiate?
So we can first start with the location where they are present. So GAVE, as the name implies, would predominantly be along the antrum, and PHG we are more likely to see along the fundus and the other part of the stomach. So in addition to that, the visual appearance is also different. GAVE can have two forms. It can have a linear appearance or it can have a nodular kind of appearance in the antrum, while PHG can have a characteristic snakeskin type of appearance wherein it appears like an edematous bowel wall instead of something that is localized to a particular point.
Yeah. No, I agree almost completely. This thing of linear pattern and in the antrum, is that in cirrhosis or is it in patients without cirrhosis? In cirrhosis, is it really restricted to the antrum?
As far as I understand, the majority of the lesions would be in the antrum, but it can be present other places as well.
Yeah. Arun, you wanted?
Sir, classically in cirrhosis, it's described as diffuse, and all the other conditions are more likely associated with the classical watermelon appearance.
Good, very good. So, this is how we try and differentiate. But before that, just take home messages very quickly so we can get into it. This is what you should know. Mucosal changes may be portal hypertensive gastropathy that is related to portal pressure and it's related to congestion. And so your treatment is non-selective beta blockers. You have vascular ectasia which is related to vasodilatation. Your initial treatment is going to be endoscopic. Okay? Everyone very clear? That's the basic thing you have to go home with. Now let's go a little further with PHG, because when you see the cobblestone appearance, that isn't always PHG. Usually portal hypertension, mostly cirrhosis, gave liver disease, mainly cirrhosis, okay? And it tends to be more the diffuse variant, and I'll show you pictures of that. If you don't have liver disease, typically connective tissue disease or chronic kidney disease, you tend to have a watermelon variant. That's your second take-home message. Is this clear how you differentiate? Okay. Now endoscopically, portal hypertensive gastropathy tends to be proximal, vascular ectasia tends to be distal, and we'll talk about the A in the GAVE in a minute. Gastropathy has a mosaic pattern, but GAVE is typically with red spots. So let's go over it here. Mosaic pattern on white light, narrowband imaging. When you have red spots over a mosaic pattern, that makes it severe gastropathy. So this patient has severe gastropathy. Are you all clear on how you diagnose severe? Okay. Now let's go a little further. Caution here, and this is a paper from PGI. Mosaic pattern is not specific for portal hypertensive gastropathy. Most patients, so this study looked at patients with cardiac failure, almost everyone had this cobblestone appearance. You see it with H. pylori, you can see it with amyloid, you can see it with gastric lymphoma too. So basically, don't make an endoscopic diagnosis of PHG. You need to know the appropriate clinical setting. Okay? Now let's come to the vascular ectasia. It can be in the antrum, a linear pattern, that is the watermelon variant. You'll see this classically in connective tissue disease, but this patient actually had cirrhosis. And you can see also the lesions in the cardia. The diffuse variant, this is typically what you're going to see in cirrhosis. You're not going to see this. You're typically going to see this, and it tends to be a little more extensive. So use GAVE if the vascular ectasia are only in the antrum. If it's more diffuse, you cannot call it GAVE. Just in general, best and safest, use gastric vascular ectasia as a generic term. Okay, so this is how you're going to report endoscopically. Okay, again caution, not specific for cirrhosis, connective tissue disease, cardiovascular disease, respiratory failure, chronic kidney disease, but typically this is the watermelon stomach. Okay, so now we've identified the lesion. Difficult here. So what do you think? Who's next? Manas, your turn. Do you think this is severe PHE or do you think this is diffused vascular ectasia?
Diffuse vascular ectasia.
Yeah. I think sometimes it's difficult, okay? I think it's very difficult. So who thinks this is severe portal hypertensive gastropathy? Who thinks this is diffuse vascular ectasia? So almost everyone? Okay, so that means almost everyone is going to treat with what? Okay, so actually I was not that sure, okay? So you can see a little bit of a cobblestone appearance in here, the extent of the involvement too. So there are a few things you must do if you're not sure. If you're not sure, how would you treat it, Arun? Or no, Rohit, I think it's your turn. If you're not sure, how will you treat?
We'll add, if the patient already has cirrhosis,
No, you hadn't started treatment. So if you saw this, you don't know what it is, what would you prefer if you're not sure?
So we'll do a biopsy to confirm.
If you've got an extremely good pathologist, I'll show you slides in a bit, but if you don't have a good pathologist, I want you to be able to rely on your eyes, okay? How will you treat this? Anytime you're not sure, remember the pathologist is also not that sure.
So we'll add beta blockers.
Yeah,
If
and why beta blockers?
If
Why
it is
not
PHG, it will respond to beta blockers.
But if it's vascular ectasia, it won't respond.
respond.
So then why do you use beta blockers? I agree with you, but why do you use beta blockers first if you're not sure?
Because if the patient has cirrhosis, the other pleiotropic effects of beta blockers would also benefit the patient.
Just remember, PHE is much more common. It's a common lesion. Vascular ectasia is not that common. Okay? So when in doubt, treat as PhD. And remember, beta blockers are cheap, you're safe. Okay, start that first. If you have a doubt, histology. You spoke about histology, Rohit. What is the pathologist going to look for?
In GAVE, there will be dilatation of the vascular channels and there will be fibrin deposits.
Good. But you have to have a very good pathologist. You're not going to get many good pathologists who know this. So thrombi is typical of vascular ectasia, spindle cell proliferation, I'm going to show you pictures, and fibrohyalinosis. So you can see thrombi, I'm not seeing it well from here, I can see it on my screen. You can see fibrohyalinosis here, okay? And then, expert pathologists, very hard to find. If they're really good pathologists, in a little while they'll be at some other place, okay? So learn how to make the diagnosis on your own and on treatment response. I think Fujinon makes this eye scan, and apparently, I don't use it, but my endoscopy colleagues tell me they can make out vascular ectasia much better on this eye scan. Who uses an eye scan here? You find it useful? Okay. So management, okay? So your initial treatment, now we're coming back. You know the diagnosis. Who's going to start beta blockers? Argon plasma coagulation. I don't want to see any hands up, please. And tips, I don't want to see any hands. No other hands. Beta blockers, simple. This is how you start. Now specific treatment, okay? Some of them bleed. You'll actually see blood dripping. They can present with hematemesis. It's not common. So if you look across all severe portal hypertensive gastropathy, about 10% of the time, you can see them actually dripping blood. So the acute bleed, how are you going to treat that? Whose turn is it, Narendra?
So terlipressin, somatostatin or octreotide, like we treat variceal bleed.
So treat it like a variceal bleed. So whatever you have, start using that. But it still drips. What do you do then? Because when you start that and you go in endoscopically, you see it. What do you do?
Tips.
What's that?
Tips. Transjugular.
You don't try anything endoscopically?
Not EPC in this setting.
It doesn't last long, but you have to, till the octreotide or terlipressin or whatever works, then you can just try and touch up these lesions, okay? And by the end of this, just the active bleeding spots, don't go widely, bleeding will be controlled, then put them on non-selective beta blockers, okay? This is acute bleeding, you're not going to be seeing this too often. What if you tried, back to you, Narendra, did not work? What will you do for the acute bleed? You said it before.
Tips, sir.
Then you will do tips,
Tips.
okay? So if it's refractory bleeding, you will do rescue tips. Most often you're going to see patients with chronic bleeding, start them on a non-selective beta blocker, and if there's refractory bleeding, do rescue tips. What is refractory bleeding? Whose turn? Rohit? How do you define refractory bleeding? I have a simple definition. What's yours?
The failure to control bleeding with the initial endoscopic or medical management.
And what do you mean by failure? No, so my definition is very simple. Patient is tired of whatever you're doing. You have tried everything, it's not working, it's time to do something else. Okay, so this is my definition of refractory bleeding. That's when I do something else. Okay. Now, what's your initial treatment going to be here? Non-selective beta blockers? APC? Good. Tips? Other? Okay. Who's turn? Arun? I don't know which order I'm going. I think. Agree? Or somebody your turn?
So in
Okay.
addition to APC, we can also try other options like band ligation in selected cases if we have very localized score.
But your initial treatment
Yeah, initial would be APC. Yes.
will be, okay. So we'll talk about band ligation in a bit. So these are the options, and we're going to ask a question on iron. Remember, we say iron, we really need to know how to give iron. So iron replacement, red cell transfusions as required typically if hemoglobin drops below 7. And then you try specific treatment, which is endoscopic and pharmacological for selected cases. Okay. Show of hands for true and false for iron. Well, let's see first, who's prescribed iron? Almost everyone. Okay. So let's have a true and false. All iron preparations are equally effective. No? So some better than the others. Which one do you prefer?
All are actually equal.
Good. Oral iron 3 times a day, highest benefit. Show of hands. Twice a day? Once a day? Okay. What do you think? Manas, your turn. How do you give iron?
I will prefer injectable iron here, sir.
You don't start oral?
Oral, I will not start.
Arul?
Sir, in the other populations, they've just, like in CKD and all, they've said that we may be over-treating with oral iron. We can give like 2 or 3 doses a week of oral iron is also
Very
effective.
Good. Very good, because it's, so we'll get into that. If you give vitamin C, is iron absorb better? Okay. So intravenous iron, if patient does not tolerate oral iron, ferritin levels do not improve, or anatomy, gastric bypass or so, not in this patient, does not allow oral iron. Who will prescribe IV iron here? Good. This is your indication for IV iron, okay? Otherwise it's going to be oral. Intravenous iron high anaphylaxis risk? More hands? No. Put your hands down. What do you think? It's very low. It's very low, okay? So all iron preparations equally effective. Pick the cheapest, ferrous sulfate. I think it's got 65 milligrams if you get the 324 milligram tablet. False. I agree with you, Arun. Every other day is also okay in these patients. With vitamin C, up to 30 milligrams helps iron absorption better. These are the indications for iron, and it really does not have a high anaphylaxis risk. What people described as an anaphylactic risk was actually an infusion reactions where they tend to get a rash. Just give the iron slowly, and there's timing for depending on which preparation. So is everyone clear how to replace iron? It's very important in liver disease. Okay. Now, vascular ectasia, endoscopic management. You have different modalities. What's the first modality you use? Always APC? Okay. Cryotherapy. Who uses cryotherapy? Which it's band ligation? Okay. So generally, the evidence for efficacy is low in all these studies. They're all small studies, no randomized studies. Okay? So let's start first here. APC, remember the settings? First line treatment, not very practical for diffuse disease. Pulse treatment, paintbrush technique that you take it in a line, but that's only for this side, others it's focal pulse. The settings are 30 to 60 watts, 1 to 2 liters minute flow rate. Bleed control, usually good. What are the complications you have? Rohit, your turn. So with APC, what are the complications?
The patient can have pain post-procedure,
Pain post-procedure, good?
ulcer formation,
Good. What am I showing you here?
hypertrophy.
Why? Has anyone seen this post-APC? Nodding. Why do you get it? Someone?
So generally there is vessel alteration, so you can get bleeding hyperplastic polyps which can develop.
Why do you get the hyperplastic polyps? Why?
So because of the injury, healing happens in a disorganized way.
Why? So what should you do to prevent this? You should not see this.
Like you should start, and come proximally and don't go very near to the pylorus.
So this is a patient who is running hemoglobin of 5, treated very aggressively. Don't be aggressive in your treatment with APC. More is not better in these patients, okay? So the complications are hyperplastic polyps, and this is due to multiple high power settings. Too many sessions too frequently. What's the interval you want to use here? Between sessions. 1 week, 2 weeks, 3 weeks, 4 weeks. 1 week, 2 weeks, 3 weeks, 4 weeks, 5 weeks. Good. Somewhere 4 to 6 weeks is good in these patients, okay? Because look at this patient. These are the number of polyps removed. You can get bleeding with these polyps. They get gastric outlet obstruction. They come with you with abdominal pain and vomiting. So you have to, and you're right, ulcer bleeding, so PPI treatment following this session in here. Again, aggressive treatment can cause pyloric channel stenosis. So generally avoid aggressive coagulation. Is that clear? Okay. Now, this is a little different. If it's diffuse, then you use cryotherapy. Who has cryotherapy in their hospital? Go at night, because dermatologists are never there at night. Steal their CO2 cylinder. They have everything. So we get our CO2 from the dermatologists, okay? So you it causes a frostbite. Dermatologists use it for skin lesions. So it's very easy to use. The problem is you use a lot of gas, so you need to use you need a venting tube to vent the carbon dioxide. So the advantage is it's easy to use. The disadvantage is it tends to be very hazy. And again, very limited later. So this is band ligation. When do you use band ligation? Narendra, is it your turn?
After several sessions of APCR field then.
But if it continues to look the same as the first time, will you still use banding? Because how will you select what to band? Because you've got a lot of ectasia. Use it. It's typically what's called the nodular type of GV, which I showed, right? So use it for that. Start distal, come proximal. What's the problem with them? What do you tell them after the endoscopic procedure? Liquid diet, good. You put multiple bands, but again they get features of outlet obstruction. So liquid diet for 24 to 48 hours. Follow up, don't be aggressive about this, 4 to 8 weeks for band ligation, because they tend to get scarring, as you can see, and banding ulcers. So 2 meta-analysis, 194 patients, generally they do well for some time. So this is the summary of the approach to portal hypertensive enteropathy and small bowel ectasia. We'll come into treatment. GI bleeding with negative endoscopy. What do you want to do next? Who wants to do capsule next? Who doesn't want to do capsule next? What do you want to do next? What are you going to do? So patient has a bleed, you did the upper endoscopy, you don't find a lesion, you did a colonoscopy, you don't find a lesion. You want to use a capsule.
Probably a cross-sectional imaging may be recommended at this stage. We can do a CT portography to see what kind of vessels are there and if we have a major collateral that is bleeding.
So that is the varices. So you're looking for ectopic varices,
yes.
okay?
Yes.
And then what will you do?
So depending on the location, we can probably plan some management. If
And CT gives you a rough location, okay? But is that the first thing that you'll do?
If a patient has a negative upper and colon, then probably.
So remember, this is likely to be a small bowel source of bleeding. And most bleed are related to ectasia, enteropathy, or ectopic varices. Do an extended upper endoscopy. So that's a pediatric colonoscope, because most bleeding lesions are in the duodenum or in the first about 30 centimeters of jejunum. So you can see almost all causes. It's only if you don't find the lesion, then you do, because then life becomes very complicated for you. Because you do a CT scan, the next thing you're going to ask is double balloon or single balloon enteroscopy. And generally, in these, when you're treating, for me, refractory is very soon. If they require more than 2, it's very complicated to get all this scheduled. I'll go for something else. Okay, so early consideration of pharmacological therapy. So everyone's clear how to evaluate small bowel bleed? Okay. Now, PHG has not responded, GAVE has not responded. Who wants to do tips? Who wants to do tips for PHG? Who wants to do tips for GAVE that has not responded? Okay. What do you think? Whose turn? Manas?
For PHG, we can refractory, then we can go for tips. However, for GAVE, liver transplantation.
Okay. Use straightway liver transplant. Okay. So who thinks they respond equally well? But we got the answer there. So there are 2 studies which have looked at this. So we know tips usually effective for PHE. So that will tell you the pathophysiology is related to high pressure. Usually not effective in vascular ectasia, which tells you it's not related to high pressure. So don't use tips for GAVE. So what do you want to use next? Who's next? Arun? GVE, tried endoscopic
We can
treatment.
try oral thalidomide IV iron, oral thalidomide, then we can use some of the anti-VEGF.
Good. I don't know about thalidomide. I know the Chinese study, none of them had cirrhosis. We've not had very good luck with thalidomide, but yes. So we'll come into pharmacological treatment. So you use estrogen, progesterone. Remember, it's very simple, the cheapest treatment. Bevacizumab, VEGF, thalidomide. And there are many others. Again, low quality, and potential use is supplement. Liver transplant, very good, but only a small number of patients actually can go to liver transplant. And why is that, Manas? Is this more common in younger people or older people? The vascular ectasia.
One sir.
Yeah, so often they're not candidates for transplantation for other reasons, okay? Antrectomy is no longer recommended. So we're only going to discuss bevacizumab and estrogen, progesterone. So low blood flow causes VEGF production, and so you use bevacizumab. Bevacizumab inhibits vascular proliferation, so don't use it if a patient's requiring surgery or is going to come to liver transplant soon. Not indicated. Crohn's disease risk for fistula, don't use it again. This is what's used, 5 milligrams per kilogram. We don't need to go over the dose. You may need to use it frequently. We give it every 2 weeks for 6 doses. Hypertension, cardiac failure occur in these patients. But the most important is the infusion reaction. Don't give it very quickly. Tell your nurses, we follow the 90, 60, and 30-minute rule. First infusion over 90 minutes, next over 60 minutes, and the third over 30 minutes. Okay. So these are your take-home messages. Chronic bleeding, iron replacement, beta-adrenergic blockers. If the hemoglobin is stable, continue beta blockers. If the patient is transfusion dependent, meaning if he's not, that means it requires only the occasional transfusion, still continue. Don't get too excited. But if they're requiring transfusion, sometimes they require it every week, then you go to TIPS. Vascular ectasia, chronic bleeding, refractory to endoscopic treatment. We ask for a history of breast or uterine cancer, because then you cannot use oral contraceptives. If they have this history, use bevacizumab. If not, try low estrogen. It's really very useful. Especially in postmenopausal women, I told you they are older, tell them to throw away the dummy pills. Because if they use the dummy pills, they get withdrawal bleeding, and that scares everyone because that would indicate this is cervical cancer. If the hemoglobin is stable on oral contraceptives, we will continue. If it's not, bevacizumab. If still not effective, we may go to higher dose of bevacizumab. We've never really had good luck with thalidomide. So take-home messages, you must know the difference between the two. Beta blockers, mainstay of portal hypertensive gastropathy. Vascular ectasia, endotherapy is the mainstay of therapy. And if that fails, try oral contraceptives or bevacizumab. Okay? All iron preparations equally good. Once daily or every other day. And specific treatment depends on what sort of expertise you have and what the lesion is. So, now, let's see a show of hand. I'm very confident I can treat PH. Oh, I didn't do a good job. Okay. I'm very confident I can treat here. I'm very confident I can treat both. Good. Okay, now let's go to the next. It's a very quick case. It's not a common case. Questions at the end, okay? It's very quick case. You won't see it commonly, but anyone doing transplant should be aware of this. This is a patient 6 years post-transplant, 1 day history of severe abdominal pain, nausea, vomiting, and fever. So she comes in with a temperature of 39, 5 hours later, that's when we saw her. She was in the ICU, temperature is 35. Pulse rate has gone up, blood pressure has dropped, respiration rate has gone up. Look at the labs, hemoglobin has dropped, white cell count has gone up, bilirubin gone up, AST gone up, ALT gone up, amylase and X-ray abdomen normal. Whose turn? Arun, Rohit, was it your turn? What do you think is happening? We don't want the diagnosis yet. What do you think is happening? You're looking at the labs, what do you think is happening?
Bacterial sepsis.
From what?
Looks
Why is the abdominal pain severe? I mean, she's got diffuse tenderness. What would cause severe tenderness? Which infection would cause severe tenderness?
So some liver abscess, like some
So liver abscess, reasonable choice, but why diffuse?
diffuse is difficult. So
Okay. Let's look at the plasma. When we saw her 5 hours, this is what the plasma looked like, and this was 12 hours later. This is what the urine looks like. You have to diagnose this the moment you see it. What's your diagnosis now? What's happening?
So the patient is having hemolysis, probably rhabdomyolysis, which can explain both the enzyme.
Rhabdomyolysis, we don't have the history, but hemolysis, I agree. So
Yeah.
which infection is associated with such extensive hemolysis? That is the take-home message. When you see hemolysis, which infection is it? Is it a gram-positive or a gram-negative?
Generally positive, cause hemo
Cocci or bacilli?
bacilli.
Which one? Very good.
All
The more aggressive I am with question means you're doing well.
so all GPBs can cause shock with fever.
But like this? Okay. Who thinks this is CMV colitis? PTLD? Portal vein thrombosis? Cobra bite? Cobra bite? Do you agree? Why is this not cobra bite? From what I remember from my forensic medicine.
Neuroparalytic.
Very good. So my forensic medicine was my nightmare. I almost failed. I barely passed. But what I remember is cobra and crate are neurotoxins and vipers are hemolysis. Okay? So this is fever with intravascular hemolysis and shock. We saw the patient started on penicillin G, 20 million units as a continuous infusion. This is the treatment. But she died 11 hours later. This is what the liver looked like. You were right on that. This is what the smear from the liver abscess showed. What's your diagnosis now? Is this gram-positive or gram-negative? Bacilli or cocci?
Staphylococcus.
Which one? Is it staph is a cocci. This looks to me like a bacilli. It's a rod. So, and it's gram-positive. So which are the gram-positive bacilli?
Sir, like I have a code to remember.
Good. You're right. So which are the ones? I think you have the mnemonic.
@del,
Good, good. Little more. It's delta. Tell me what D is.
So diphtheroids.
Good,
Erysipeloids.
good. L is for list
Listeria
and
and
lacto.
Bacillus.
Yes, L. I'm sorry, T
T.
is the tetanoids
Yeah.
and A
Anthrax.
is the anthrax. Very good. So which one of these is it?
This is tetanoid.
Which one?
Such fulminant presentation perfringens is very well known.
Good. This is classic perfringens infection. Is perfringens common in India? No? Are you sure? I'm going to show you data. It's among the highest elsewhere. It's common in the gut. Dr. Dilavri will remember if we used to see in PGI, when gynecology called us for a septic abortion, especially if it was self-induced, and they had this picture, this was Clostridium. Okay? So this is perfringens. So this is a study from India. Patients with diarrhea. In the US, it's the second most common cause of watery diarrhea. If your normal immunity, nothing to worry, you get some abdominal pain, watery diarrhea, no antibiotics. It's a killer in patients who have who are immunosuppressants. So see, this is the antibiotic profile in India. It's common in the GI and genitourinary tract. You can get it in cholangitis. 4% of cholangitis will have Clostridia. Type C is the most lethal. Okay, it usually comes from uncooked meat. So your take-home message, you're not going to see it commonly, but if you see it, if you don't make a diagnosis in minutes, the patient will die. And we thought we made a diagnosis quick, but it was 5 hours after the patient first came in. So consider it in immunocompromised patients with jaundice, high fever, and hemolysis, especially if rapidly progressive. Start penicillin G. 20 million units IV as a continuous infusion. If they're penicillin allergic, then you can try clindamycin. Mortality is 70 to 100% in these patients. Okay? Now, last part, we have a little less time than I thought we'll have. Who says, I know how to treat hyponatremia and cirrhosis? Anyone? No. Who says, I'm not sure how to manage hyponatremia? It should be everyone. Okay. Who says, thank you for choosing this topic because now I can go to sleep? No? Because people find oh, good. Because hyponatremia is a very boring topic, but we'll try and make it interesting. Okay? So 48-year-old male, serum sodium is 128. At what level are you going to hospitalize this patient? I just want to know what you do. There's no right or wrong. And towards the end, if you have a few minutes, I want Raki to make some comments because she's sort of extremely well known internationally for her work and probably knows more about hyponatremia than me. Okay. Who admits at 130? 125? 120? Less than 130 and symptomatic? Okay, so we'll come into that. So generally, but you can pick whatever you want. This is what I do. So how common is hyponatremia? Is very common. But don't get too worried because the people you need to get worried about account for only 2.4% of all cases with hyponatremia. Panel, what level do you admit? Manas?
It is, sir.
120, yeah. You
Or
can pick.
symptomatic.
What's that?
120 or symptomatic.
Yeah. And typically it's unusual to be symptomatic unless you're below 120, okay? So patients with cirrhosis have a decrease in the effective arterial blood volume. They get ascites, renal vasoconstriction. But it's the water retention that gives rise to the hyponatremia. Okay. Do you want a history of TERP or hysteroscopy? Anyone wants this? Is it important? Good. Why?
There is a lot of irrigation with free water that can probably lower the sodium.
Probably something different. Do you want to check volume status? Very important. History of TERP or hysteroscopy is very easy if it's happened in the previous few days. Usually it's a patient with compensated cirrhosis who comes. Will you measure serum osmolality? You want to measure potassium? Why? Does treatment of hypokalemia help?
Yes, sir.
Yes,
Because
it helps a lot. You want to measure urine sodium? Good. So this is generally the approach to hyponatremia. Less than 130. Measure serum osmolality. I do it a little different, but this is the guideline. If it's normal or high, typically this is TERP or hysteroscopy because it's the irrigation solutions that they use which get absorbed. But typically it's low osmolality so that, high, if they don't have the history of this, we don't do osmolality to start off with. If they've got renal failure, that's easy enough. That's the cause of hyponatremia. The problem is if they don't have renal failure, we look for diuretics. Should you look for thiazides? Narendra? In fact, the most common cause of hyponatremia, other than severe liver disease, is thiazides. And why is that? Because, especially with patients now going to have mast cell, they have hypertension, their primary care person has put them on thiazides. They come to us, the only two drugs we know are spironolactone and furosemide, so we add that onto the thiazide and that causes the severe hyponatremia. So when you start diuretics, make sure that they're not already on thiazides. So we stop thiazides, and typically they resolve. But if they don't resolve, this is the hyponatremia of cirrhosis, okay? Then you measure the urine sodium. If the urine sodium is high, they're losing it in the kidney. If the urine sodium is low, they're losing it somewhere else, and typically it's in the gastrointestinal tract, or it's dilutional, which is typically what patients with severe hyponatremia have. So take a good history, measure urine sodium, good enough for most patients. Okay. Fluid restriction if sodium less than 130. Who restricts fluid at 130? 125? You give sodium and you replace. If the serum sodium is less than 125, who does that at 125? 120 and asymptomatic. 120 with symptoms. Okay, good. 115 without symptoms. To restrict fluid, you restrict to 1500 ml. Who restricts to 1500 ml? Is it effective? Okay. And fluid restriction to 1000 effective? Good. How much fluid do you restrict?
Will not restrict fluid. If it is hypervolumic, then only we'll restrict fluids.
And how much do you restrict?
According to urine output only.
Very good. You must look at urine output. So it's really severe. So they present with fatigue, confusion. That's when you have to start admitting them. Remember, it's a little difficult. It's unusual for them to be symptomatic below 120, unless it gets below 120. Correction of hyponatremia is only to improve symptoms. It doesn't make them any better otherwise. Correct sodium very slowly. If you correct it too rapidly, you get osmotic demyelination. Who's seen osmotic demyelination? Yeah, see, so you have to be very careful about that. So for fluid to be effective, urine output minus 500. And I hardly ever restrict fluid except just before transplant, because patients will stop liking you. It's very difficult for them. You're already restricting so many things. How do you replace normal saline? 3% saline? 500 milliliters of boluses? Yeah, use only boluses, okay? So this is how we typically would like to manage. If it's more than 120, if they have symptoms, take them in. This is not common. If they have no symptoms, they can be as an outpatient. If you take them in, but the urine sodium if the serum sodium is over 120, don't do much. Just look at their sodium. Typically, they can self-correct. But less than 120, we take them in as an inpatient. Just monitor the serum sodium, okay? Because then you know whether they've been drinking too much or not. If the patient is edematous, this is classically hypervolemic hyponatremia. Yes, we will collect sodium when it's low, but here you would also like to perhaps give furosemide for them just so that the volume is not too much. But true hypovolemia, give them saline. If you're not sure, you have to be a little careful about who is going to get osmotic demyelination. Monitor them carefully, okay? So most important, don't correct it too rapidly. So I generally start 3% saline in asymptomatic less than 115. Why? Because I've seen seizures below that. It's just what I do, 115. Okay. Osmotic demyelination. What is the brain showing here? What is this sign called? Does this look to you like a flower which is upside down? Which flower? Oh, we don't have time. It's called the inverted lotus sign. So I had something, but maybe Rakhi, we have only 1 minute left. You want to talk about what you do for sodium? Because what I'm telling is what I do. Maybe you can go to the microphone. especially pre-transplant. Let's say if you got 1 week pre-transplant, what do you do? And if you got 1 day pre-transplant, what do you do?
So you've very nicely alluded to the entire algorithm, but I would just like to add the renal functions there and the degree of the volume status, which will also determine the kind of therapy that we'll be using for such patients.
I agree.
Because if there's significant volume overload and the sodium is very low, you have to start your renal replacement. And for that purpose, then you try to bring up the sodium to match up with the dialysate. And if you have a preserved renal function, then there are other therapies which you can use for making the excretion from the kidneys, like using vasoconstrictors, giving 25% albumin, and also adding Vaptans if the patient is conscious and having preserved renal function. So those could be effective therapies in the short term when you're planning to increase the sodium prior to liver transplant. Those could.
Yeah. And I think we have finished. Ajay, we are done right now? 2 more minutes. Okay. So, so this is osmotic demyelination syndrome. So remember, it does not occur immediately after you've corrected sodium too rapidly. It occurs about 48 hours later. So watch these patients very carefully, and if you've corrected the sodium very rapidly, make sure you're going to dilute them so that you can decrease the sodium. You get it following terlipressin. This is from Piragenis in Barcelona. So post-terlipressin, remember you're using it a lot, you can get hyponatremia in these patients. Okay. So your goal, not more than 8. And this is generally, I think Raki gave you what you would do pre-transplant. Generally below 125, I know this is impending hepatorenal syndrome. I discontinue beta blockers, I discontinue diuretics. Immediately pre-transplant, post-transplant, the serum sodium is about 132 to 135. We don't want to correct more than about 8. So pre-transplant, I want to source the serum sodium about 125 to 128, okay? And don't forget, you must correct hypokalemia, okay? Any questions? We have 1 minute. Someone had a question, someone, any of the 3 cases. Virendra, do you want to make a comment?
Yeah, very well covered the hyponatremia, but we don't give the sodium, the hypotonic saline we don't give. The problem is that these patients will have a worsening of ascites. So if you are planning the transplant, you can give it because you want a very fast correction. Otherwise, if you are not planning the transplant, don't give the sodium, and otherwise the ascites will worsen. You do the other things. There are many things which need the improvement. These patients are with the sepsis. These patients must be consuming the high salt.
I think we have to close. I've got to. Anyway, thank you to the panel, my team again. I hope I see you next year, okay?